Coagulation Chapter Summaries. Chapter 15, Overview of Hemostasis and Platelet Physiology, Summary Points. Normal hemostasis is dependent on a system of checks and balances and relies on four main components: vessel wall endothelium, platelets, hemostatic proteins, and fibrinolytic system. Platelets are involved in both primary and secondary hemostasis. Primary hemostasis represents vasoconstriction and the formation of a platelet plug. Secondary hemostasis represents the creation, followed by lysis, of the fibrin clot. Platelets are segments of cytoplasm derived from megakaryocytes. Inactive platelets circulate as discoid structures approximately 2 to 3 micrometers in diameter. On activation, platelets undergo 5 reactive changes: adhesion, shape change, secretion, amplification, and aggregation. Most coagulation proteins are produced in the liver. Platelet adhesion and aggregation are mediated by von Willebrand factor, fibrinogen, and platelet glycoproteins. PFAs have replaced the bleeding time for the overall evaluation of platelet function. Platelet aggregation can be performed using either PRP or whole blood. Clot formation is initiated through the extrinsic, intrinsic, and common hemostatic pathways. The fibrinolytic system comprises plasminogen, TPA, alpha-2AP, and PAI1, and functions on the lysis of clots after they have formed. The traditional coagulation cascade model of clot formation is slowly being replaced by the cell-mediated model. Naturally occurring anticoagulants are hemostatic proteins that maintain the hemostatic balance by inhibiting clot formation. Protein C, protein S, antithrombin, and TFPI are naturally occurring anticoagulants. The PT and APTT are used as screening assays for acquired and inherited bleeding disorders. Monitoring anticoagulant therapy and evaluation of the acutely bleeding patient. The INR was adopted by WHO in 1983 to standardize PT reporting for monitoring oral anticoagulant therapy. Mixing studies are performed to evaluate the cause of an abnormal PT or APTT and can identify a factor deficiency versus a circulating inhibitor. Chapter 16, Quantitative and Qualitative Platelet Disorders. A normal platelet count is 150 to 450 times 10 to the 9th per liter. Decreased platelet counts lead to bleeding of mucosal membranes such as gingival bleeding, epistaxis, purpura, and petechiae. Pre-analytic variables that may lead to thrombocytopenia include improper mixing of tubes, improper anticoagulant used, and inadequate amount of sample collected. Acute idiopathic thrombocytopenia, purpura, often occurs in children who have a dramatically reduced platelet count while recovering from viral illness. Chronic idiopathic thrombocytopenia, purpura, occurs in adults as a result of IgG antibody produced against platelets. Thrombotic thrombocytopenia, purpura, and hemolytic uremic syndrome are consumptive disorders of platelets. Individuals with TTP present with fever, microangiopathic hemolytic anemia, neurologic complications, thrombocytopenia, and renal failure. Individuals with HUS are predominantly children and present with fever, bloody diarrhea, microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. Von Willebrand disease is a platelet adhesion disorder characterized by decreased or absent von Willebrand factor. Von Willebrand disease is the most common inherited qualitative platelet disorder, affecting 1 to 3% of the world's population. There are 3 primary types of von Willebrand disease: type 1, 2, and 3. Bernard-Soulier syndrome is a platelet adhesion defect characterized by decreased or absent GPIB. Glanzmann's thrombasthenia is a defect of platelet aggregation characterized by an absence of GP2B/3A. Platelets from patients with von Willebrand disease and Bernard-Soulier syndrome do not aggregate with ristocetin. The platelet release function is impaired in inherited disorders including Chidiac-Higashi syndrome, Hermansky-Pudlak syndrome, Wiskott-Aldrich syndrome, Gray platelet syndrome, and thrombocytopenia with absent radii. Aspirin impairs platelet function by interfering with the synthesis of thromboxane A2, a potent platelet aggregating agent. External conditions that alter platelet function include drugs, paraproteinemias, uremia, and use of plasma expanders such as dextran. Skin, collagen, and blood vessels are essential elements in the hemostatic system. Any inherited or acquired abnormality in any one of these components of the vascular system leads to mucosal bleeding, such as purpura, petechiae, ecchymosis, or telangiectasia. Chapter 17. Defects of plasma clotting factors. Summary points. Platelets with recurrent bleeding episodes must be evaluated for an inherited bleeding disorder. Bleeding falls into two main categories: open bleeds or closed bleeds. Plasma clotting factors need to maintain approximately 30% activity to achieve adequate clotting. The factor VIII molecule is carried into plasma via von Willebrand's factor. Hemophilia A and hemophilia B are generally acquired, sex-linked recessive disorders. In hemophilia A, factor VIII is deficient. In hemophilia B, factor IX is deficient. Women are carriers of the defective hemophilia gene. Individuals with hemophilia experience prolonged bleeding from minor wounds. Individuals with hemophilia may experience many types of bleeding, including joint bleeding, leading to hemoarthrosis, hematomas, umbilical cord bleeding, or mucosal bleeds. In patients with hemophilia A and hemophilia B, the APTT is elevated. Current treatment for hemophilia consists of recombinant factor products. In the United States, most individuals with hemophilia use factor concentrates prophylactically. Prophylactic infusion of factor concentrates minimizes the physical disabilities that may occur from unexpected bleeding episodes. Of individuals with hemophilia, 10 to 30% develop factor VIII inhibitors. Individuals with factor II, 5, 7, and 10 deficiencies may have minimal bleeding. Prothrombin complex concentrate is used to correct deficiencies in factors 2, 7, 9, and 10. Prothrombin G2021A is a mutation of the prothrombin molecule. Factor V lead-in is a genetic mutation of the factor V molecule that predisposes to clotting episodes. Deficiencies of factors 11, 12, Fletcher, and Fitzgerald usually lead to increased thrombotic events. Factor 13 is unique among clotting factors because it is a transglutaminase. The other clotting factors are proteases. An inherited deficiency of factor 13 may lead to poor wound healing and spontaneous abortions. Liver disease, renal disease, and autoimmune processes may lead to deficiencies in clotting factors that cause bleeding. Vitamin K is a fat-soluble vitamin necessary for the activation of factors 2, 7, 9, and 10. Vitamin K is available through the diet. Small amounts are synthesized by normal intestinal flora. Newborns are vitamin K deficient and are given vitamin K at birth to avoid hemorrhagic disease of the newborn. Vitamin K depletion results in prolonged PT and PTT. Warfarin, or Coumadin, is a therapeutic anticoagulant and a vitamin K antagonist. Chapter 18. Fibrinogen, thrombin, and the fibrinolytic system. Summary points. Fibrinogen is the key substrate of the coagulation and the fibrinolytic systems. Fibrinogen has the highest molecular weight of all the clotting factors. Thrombin acts on fibrinogen, converting it to fibrin. Stabilization of fibrin by factor 13 and calcium results in an insoluble clot. Plasminogen is converted to plasmin primarily through tissue plasminogen activator and then proceeds to destroy the fibrin clot. Afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia are all inherited disorders of fibrinogen. Each of these may also be an acquired disorder. Naturally occurring inhibitors of fibrinolysis are plasminogen activator inhibitor 1 and alpha-2 antiplasmin. The byproducts of fibrinolysis are FDPs and D-dimer. D-dimers are produced from a cross-linked and stabilized fibrin clot. Excess D-dimers indicate excessive lysis of cross-linked and stabilized clots. DIC is usually triggered by an underlying pathologic event. Patients with DIC excessively clot or excessively bleed, or both. Laboratory results for a patient with acute DIC show prolonged PT and PTT, decreased fibrinogen and platelets, and increased FDP and D-dimers. Treatment for DIC includes investigating and resolving the cause of the disorder and providing blood bank products as needed. Chapter 19, Introduction to Thrombosis and Anticoagulant Therapy. Summary points. Thrombophilia refers to conditions that predispose an individual to thrombosis. Risk factors associated with thrombophilia can be divided into physical, inherited, or risk factors. Thrombosis is the formation of blood clots in the vasculature. Thrombosis can be arterial or venous. Arterial thrombosis is mainly composed of platelets with small amounts of red blood cells and white blood cells, whereas venous thrombosis is composed of fibrin clots and red blood cells. Thrombosis may result from vascular injury, platelet activation, coagulation activation, a defective fibrinolytic system, and defective physiologic inhibitors. Physiologic thrombosis results from the body's natural response to vascular injury. It is localized and formed to prevent excess blood loss. Pathologic thrombosis includes DVT, arterial thrombosis, and PE. Pathologic thrombosis may result from inherited or acquired conditions. Thromboembolism forms when a clot dislodges from the site of origin and is released into the circulation. Physiologic anticoagulants, including AT, heparin cofactor 2, protein C, and protein S, are plasma proteins. AT is produced in the liver. It inhibits factors 2A, 9A, 10A, 11A, and 12A. Heparin increases the inhibitory action of AT. Protein C is a vitamin K-dependent protein produced in the liver. Protein C is activated by the thrombin thrombomodulin complex. Protein S is a cofactor for protein C activation. Activated protein C inactivates factors 5 and 8A. Inherited risk factors are associated with genetic mutations that result in deficiency or defects of naturally occurring inhibitors such as protein C, protein S, or AT. Elevated plasma clotting factors such as prothrombin G2021A or increased factor VIII and fibrinogen are associated with thrombosis. Most, 92%, of cases of activated protein C resistance are inherited and are caused by mutation of factor V, ARG506GLN, or factor V Leiden. Acquired thrombotic disorders are associated with underlying diseases or drugs. APL syndrome is caused by antibodies against phospholipid-dependent coagulation assays, such as APTT, which are not corrected with a 1-to-1 mix with normal platelet-poor plasma. The most common forms of APL antibodies are LA and ACA. Laboratory tests for LA, including APTT and DRVVT, mixing studies, and confirmatory studies. ACA is tested by ELISA. HIT is an immune-mediated thrombotic complication associated with heparin therapy. The antibody is produced against heparin platelet factor 4 complexes. Diagnostic tests for HIT include heparin-dependent platelet activation assays and detection of the antibody by ELISA. Antithrombotic drugs include antiplatelet drugs, anticoagulant drugs, and thrombolytic drugs. Aspirin is an antiplatelet drug that inhibits the COX enzyme and prevents formation of TXA2. TXA2 is a potent platelet-activating substance released from the activated platelets. Heparin is a short-term anticoagulant drug. It is administered intravenously or intramuscularly. Heparin dosage is monitored by anti-factor Xa assay. Warfarin, or Coumadin, is a vitamin K antagonist drug that inhibits the vitamin K-dependent coagulation factors 2, 7, 9, and 10. Coumadin is an oral anticoagulant that is administered as a long-term anticoagulant. It is monitored by the INR. Direct thrombin inhibitors such as biliverdin are alternative anticoagulants used in patients with HIT. Thrombolytic drugs include recombinant TPA and urokinase. LMWH may be used in pregnant patients or patients with PE or DVT.